Hope that this is clear. If anything, or if a problem, please let me know. And we will speak now about the treatment of glaucoma, starting by the medical treatment. There is a wide spectrum of anti-glaucomatous medications. So what you really need for those medications is to know what is the mechanism of action of these anti-glaucomatous medications and what are the contraindications for use of these anti-glaucomatous medications. So we can summarize the effect of the anti-glaucomatous medications into into three. Let's say three groups. First group will cause decreasing aqueous formation. So they will control the aqueous formation. And how can we decrease aqueous formation? We said that in the first two slides of the lecture that in the last time that the ciliary body has alpha receptors and beta receptors. In order to decrease aqueous formation, we can just block the beta receptors by beta blockers, or we stimulate the alpha 2 receptors by the alpha 2 agonists, or we can simply work on the carbonic anhydrase enzyme so that it will prevent the formation of bicarbonic acid by blocking the carbonic anhydrase enzyme. So carbonic anhydrase inhibitors are also potent inhibitors of the aqueous secretions or aqueous formation. The other pathway or the other mode of management or mode of or mechanism of action is to facilitate the outflow. This could be by increasing the aqueous outflow through the conventional pathway or the trabecular outflow, which will be done by the muscarinic agonists or the myotics or the parasympathomimetics. All are the same thing. Muscarinics are the myotics or the parasympathomimetics. So this will cause pulling off by contraction of the ciliary muscle. They will pull the angle, leading to drainage of the aqueous. Or we can use the uveoscleral pathway. We can increase the aqueous outflow through the uveoscleral pathway, which is through the prostaglandins analogs. So this is the mechanism of action. Let's now talk about the group of the drugs and the side effects. Prostaglandins analogs, there are famous drugs like Travatan, like Xalatan, Lomigan, and Rescula. So the side effects of these drugs that very commonly asked in the exams, first of all, darkening of the periocular skins and lipoatrophy. So you see the skin around the eyes is darkened and there is atrophy of the orbital fat. It could be darkening of the iris. So this patient has, this is a patient before the treatment of prostaglandins analog, and this is 6 months after the treatment. And the noticeable feature here, not only the iris hyperchromia, but also the congestion. You see the iris here was a little bit congested, but here become severely congested. This is what I was just telling you, that the prostaglandins analogs are inflammatory mediators. They promote the inflammation. So one of the common complaints of those patients that they will experience pain. And that's why also we advise those patients to put this eye drop at night. So this problems could be occurs during the night where they are sleeping. Also, one of the common side effects is the hypertrichosis. Hypertrichosis, trichiasis, and distichiasis, these prostaglandins analogs are like hair tonics. They will promote the growth of hair. So you see the eyelashes here are becoming elongated in contrast to the other eye. Also, the orbital fat is absorbed in contrast to the other eye. So this picture clearly demonstrates the effect of the prostaglandins analogs. Maybe now I even heard that some hairdressers are using the prostaglandins analogs for just making the hair longer and doing some body care. So yeah, they may use the drug in another way. Also, the prostaglandins analogs, they are inflammatory mediators. That's why they exacerbate the herpes simplex virus infection. So they may cause geographical ulcer in patients who have herpes simplex virus, and also exacerbate uveitis, causing cystoid macular edema. And prostaglandins analogs shouldn't be used in inflammatory and neovascular glaucoma. Remember, when every drug is contraindicated, they shouldn't be given for inflammatory and neovascular glaucoma. Regarding the beta blockers, so we have different categories. First of all, there are non-selective beta blockers. Non-selective beta blockers, they work on both beta 1 and beta 2 receptors, such as the levobinolol or the beta-GAN, the metoprolol, and the timolol. So levobinolol, metoprolol, and timolol, these are non-selective beta blockers, and we will say now what is the problem with the non-selection. They will cause cardiac manifestations and cause respiratory manifestations. So in order to avoid these cardiac and respiratory manifestations, there are the selective beta 1 blockers. So selective beta 1 blockers, such as the betaxolol or the Betoptic, they will be safer with pulmonary conditions, but the problem that they are weaker than timolol. So if a patient is asthmatic, which one to choose? If we have to choose a beta blocker, then selective rather than the non-selective. There is another medications which will cause intrinsic sympathomimetic activity. So intrinsic sympathomimetic activity, so meaning that it is a beta blocker. So it should block the sympathetic. However, at the initiation of the treatment, initially they will cause mild sympathomimetic activity. So as if it is agonist, it is as if it is stimulating the sympathetic. So this will result in decreasing the incidence of bradycardia or bronchospasm, such as the cartulol. The cartulol will show less effect on the nocturnal pulse and the blood pressure because it will show initial sympathomimetic activity and less effect on the plasma lipids. So those patients who on beta blockers, this will decrease the useful HDL, the high density lipoprotein. But for the cartulol, it will be less effect on the HDL, less effect, less lowering of the HDL. So speaking about the side effects of beta blockers, bronchospasm, bradycardia, increased heart block, lowering the blood pressure, CNS depression, diabetes mellitus due to decreased glucose tolerance. A sudden withdrawal can exacerbate hyperthyroidism, myasthenia gravis aggravation, lethargy, mood changes, depression, headache, allergy, altered serum lipid. As I told you, it will decrease the useful lipoprotein, which is the HDL, impotence and decreased lipido, and corneal anesthesia and punctate keratitis. Dr. Iman, could we prescribe Zalatan for patients with secondary glaucoma due to uveitis? No. As long as there is inflammation, don't prescribe the Zalatan or the prostaglandins analogs. Safer drugs will be the carbonic anhydrase inhibitors and the beta blockers combination. And alpha 2 agonists. So this will be better for those patients. The third group of drugs, it is called the parasympathomimetics or myotics or the muscarinic agonists. So these drugs or the pilocarpine, it will reduce the intraocular pressure by contraction of the longitudinal ciliary muscle. So remember when we said in the fundamentals, we said that the longitudinal ciliary muscle is attached to the scleral spur. So contraction of it will result in pulling on the scleral spur, resulting in opening the trabecular meshwork and increasing the aqueous outflow. There are two groups of parasympathomimetics. There is the direct cholinergic, which acts like acetylcholine. It's called direct action, such as the pilocarpine and the carbachol. See the carbachol, which we use intraoperatively in order to inject in the anterior chamber in order to induce intraoperative meiosis. So they will act as if they are acetylcholine. Another category of drug, which is called the indirect anticholinesterase. Indirect anticholinesterase, they will inhibit, they will provide the parasympathomimetic action through indirect pathway. They will prevent the enzyme that will destroy the acetylcholine. So they will inhibit the acetylcholinesterase. leading to abundance of the acetylcholine in the neuromuscular junction. So this will be the eicosapent iodide and carbachol. So carbachol here acts by dual mechanism, act as direct and act as indirect. That's why when you inject it intraoperatively, you will find there is dramatic response that the pupil will constrict immediately on the spot because of its dual action. And this, the word dual action of the carbachol was asked before in the MCQs. The side effects of the parasympathomimetics or myotics, it will be the pupil constriction, increased risk of retinal detachment, induced. So let me just explain. Pupillary constriction, it is simple, understandable. It is a parasympathomimetic, so it will cause myotic. So this I can also have, by the way, it has an advantage. This pupil constriction, it will increase the depth of focus, and it will be better for reading. That's why they will say that the FDA approved the myotics for presbyopes who needs a better reading. This is based on that they will cause pupil constriction leading to better depth of focus or increased depth of focus. But the problems about myotics is that they will increase the risk of retinal detachment. It will pull on the longitudinal muscles, so it will push the whole the iris lens diaphragm forward, leading to pulling on the vitreous base. If there is any weakness of the vitreous base or any holes or any breaks, may increase the risk of RD. Induced myopia, again, because of the accommodation. So parasympathomimetics will cause ciliary muscle contraction. So this ciliary muscle will cause accommodation. And this induced myopia will cause brow ache. So the patients will always complain of headache because of the myopic shift. Paradoxical angle closure. This is weird. Would you will tell me that myotics can be used for angle closure treatment? How could that they will induce angle closure? How could that myotics will have they have a side effect that they will cause paradoxical angle closure? The paradoxical worsening of the angle closure may occur due to forward movement of the lens iris after treatment with cholinergic drugs. So I told you that the treatment with myotics will cause a shift of the iris lens diaphragm. So the iris will be blocking the angle. So this is a mechanism which can worsen the angle closure. It can also punctal stenosis, cause punctal stenosis. Don't know exactly how does this happen. It will disturb the blood aqueous barrier. That's why it is contraindicated in inflammatory and neovascular glaucoma. So remember, myotics, prostaglandins analogs are contraindicated in neovascular glaucoma and inflammatory glaucoma. Also, one of the commonest side effects that it will induce some iris cysts. Another category of drugs are called the carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors can be classified into systemic drugs and topical drugs. So systemic drugs such as acetazolamide, such as Diamox, Sidamex, metazolamide, such as naftazoline, and the dichlorphenamide. So these are just oral or intravenous drugs that will decrease aqueous formation by blocking the carbonic anhydrase enzyme. There are other topical medications that can be instilled as topical eye drops, such as dorzolamide or the Trusopt, and the brenzolamide or the Azopt. The interesting thing here is that the systemic drugs are much more potent than the topical drugs. So here, don't just think that since we are giving topical medication, so it will be more effective than systemic. No. In carbonic anhydrase inhibitors, they will be more effective if they are given systematically than topically. However, the topical will be more safe than the systematic. So it is a trade-off. You can trade the safety for the efficacy. So again, what are the side effects? Carbonic anhydrase inhibitors will cause paresthesia, lethargy. So the person is typically complaining from in the next visit that I am feeling tired, I cannot do anything, I'm just all the day at the bed, I have muscle cramps. So this is very common in those patients due to disturbance in the potassium metabolism. Anorexia, weight loss, abdominal discomfort, diarrhea, impotence and decreasing libido, renal stones. This is very common and to be and asked in the exams. Those patients with renal stones shouldn't be prescribed carbonic anhydrase inhibitors. It is a diuretic by the end of the day. Aplastic anemia and hypokalemia, which will be responsible for the muscle cramps and weakness that the patient is suffering from. That's why the carbonic anhydrase inhibitors, the systemic, shouldn't be given for longer duration, shouldn't be given for more than 1 month. Another category of medications is the adrenergic agonists. So they are the non-selective and the selective. The non-selective, such as epinephrine and the dabigatran. This was used in the past before the advent of the selective agents. So these non-selective will be like causing sympathetic flare up just to lower the intraocular pressure, which of course doesn't make any sense. Nobody will give anyone adrenaline to decrease his intraocular pressure, but this is just historical. Epinephrine and dabigatran, sometimes in some tough exams, they mention the names just to see if you know the name or not. But the commonly used is called the selective adrenergic agonists. In the selective adrenergic agonists, such as apraclonidine or what's called iupidine, and the other one is called the brimonidine or the alpha-GAN. These are the selective alpha-2 agonists, so they work on the alpha-2 receptors. So what are the side effects? The non-selective side effects, it will be the sympathetic overactivity stimulation, headache, increased blood pressure, tachycardia, arrhythmia, nervousness, blepharoconjunctivitis, cystoid macular edema in aphakics and pseudophakics, adrenochrome deposits, rebound hyperemia, eyelid retraction, sympathetic overstimulation leading to stimulation of molar muscle. And regarding the selective side effects, this is very important. First of all, the tachyphylaxis. What is meant by the tachyphylaxis? Tachyphylaxis is meaning that we need to increase the it is mean tolerance. The patient is developing tolerance to the usual dose of the drug. So we need to increase the dose of the drug in order to reach the same therapeutic response. This is common side effects with the apraclonidine. It is the tachyphylaxis. Again, tachyphylaxis means that there is tolerance. The person will develop tolerance to the medication. So in order to reach the same effect, we need to increase the dose. Also, allergy. The adrenergic agonist, one of the famous side effects is that they will produce allergic conjunctivitis, like very annoying allergic conjunctivitis to the patient. So if you find in the scenario, again, the patient had anti-glucomatous medications with conjunctivitis or conjunctival irritation, most probably, the most likely is that it is an alpha-2 agonist. Dr. Islam, what is adrenochrome deposits? These are like brownish deposits from the medication. The medication itself containing the installation of this medication into the conjunctival sac will result in release of some pigments from this medication. They are called adrenochrome, appears as brownish pigmentation. So those patients who are receiving adrenergic agonists, they will receive brownish pigmentation under the conjunctiva. They are called adrenochrome. So chrome, it is a pigment, adreno, that result from adrenergic agonists. Back again to the selective side effects. Dry mouth as any alpha agonist, and lethargy. This is here, this sentence is very, very important. I'm highlighting it in red. Don't use in infants and young children. So why? Because it will increase the risk of hypotension, seizures, and apnea, because it will cross the blood-brain barrier. Also, should be used with caution in patients with monoamine oxidase inhibitors and tricyclic antidepressants due to possible drug interaction. The last category is the hyperosmotic agents. So the hyperosmotic can be either intravenous, such as mannitol 20%, or oral agents, such as oral glycerol. These are hyperosmotic agents. So it will depend on increasing the osmotic pressure of the plasma. So they will draw the fluid by osmosis from area of low solubility. Remember the solubility and the mechanisms of aqueous formation. We mentioned one of them is diffusion. So it will be the solutes will diffuse from areas of high from the high to low. So and the fluid will pass passively. So it will be that the fluid will pass from the vitreous into the plasma until the both of them will become isotonic. So this will result in shrinkage of the vitreous and decreasing the intraocular pressure. The problems about the hyperosmotic agents, they are effective, but they can cause headache because they will cause some mental confusion because of the dehydration. They will cause urinary retention because they are diuretics as well. Backache, they can precipitate acute congestive heart failure because they will cause a circulatory overload. So this fluid overload present in the circulation, if there is a problem in the heart, it will not be able to pump this excess fluid. And also it can precipitate myocardial infarction if a patient has already compromised the cardiac function. Subdural and subarachnoid hemorrhage, they can also occur. Hyperglycemia and the ketoacidosis in diabetes mellitus. Remember, it is a sugar. Mannitol and the glycerin are sugar, so they can cause hyperglycemia and ketoacidosis, and they are contraindicated in patients with renal failure and or on dialysis. So those patients should be like you are increasing the fluid in their circulation, and they are not able to excrete these fluids. Okay, so as I was asking before, so what should I do? You need to consult an internal medicine doctor. So if you are going to give this drug to the patient, ask the internal medicine if they have like high creat and urea level indicating the presence of compromised renal function. Just ask them, consult them, should you give the mannitol or not? Finally, a question which is very commonly asked in the exams is the anti-glucomatous medications that are prescribed in pregnancy. So what is the categories of anti-glucomatous medications that should be avoided in pregnancy? First of all, the carbonic anhydrase are teratogenic in the first trimester, so they should be avoided, especially in the first trimester. Prostaglandins are causing uterine contractility, so they should be avoided especially in the late trimester, because they can induce a preterm labor or abortion if they are given early. Beta blockers, the beta blockers are concentrated in the breast milk, so they should be avoided in the nursing mother because it will pass to their babies and it will cause their many problems. And brimonidine also should be avoided in the nursing mother, as it will also pass to the babies and it will cause apnea, seizures, as we mentioned before. It shouldn't be given to a child less than 2 years old. So what should we give? If a mother has a glaucoma and she is pregnant, the best is to do laser treatment, laser selective laser trabeculoplasty. It will be better. Or if we wanted to, like in the pregnancy, the most safe medication in pregnancy, it will be brimonidine. So this is like the safest among all the other drugs. Dr. Yahya, I just mentioned them. Okay, so lastly, we will talk about the laser surgical treatment of glaucoma. So starting by the laser, there is laser treatment or the laser trabeculoplasty. It is used as an initial treatment or instead of an additional drug. Like, first of all, what is the principle of the laser? It can be argon laser trabeculoplasty or selective laser trabeculoplasty. The directing the laser toward the angle, it will result in like removing of the debris and the deposits and materials which could be blocking the angle. So it will causing opening of the pores of trabecular meshwork. So it will be beneficial to raise to decrease the intraocular pressure. So We can use it like a primary treatment as in pregnancy, or as in pigment dispersion glaucoma. You remember the pigment dispersion glaucoma, we say that the laser treatment will be very effective in such cases. Or we can use it instead of an additional drug. So it can be used as a bottle of medication. So instead of we are giving the patient 2 or 3 medications, or instead of giving the patient 3 bottles, and we are risking the compliance, we give them 2 bottles and do him a session of laser. This will be helpful to increase the compliance and lowering the intraocular pressure. However, the problem is that it will need to be repeated because its success rate will decrease over time. So 50% of patients will have the same intraocular pressure over 2 to 5 years, while only 30% have this maintain the intraocular pressure after 10 years. So its effect wane over time. Patients who are aphakic and pseudophakic are less responsive for the laser, and 20 to 25% decrease in the intraocular pressure when effective. So this is the success margin, that 20 to 25% of patients or of intraocular pressure it is down, which is actually the average of the bottle medication. So average bottle will cause 20 to 25% IOP. Okay, regarding the argon laser trabeculoplasty and the selective laser trabeculoplasty will have the similar intraocular pressure effect. There is another important trial that was asked before in the advanced ICU exams. It's called the LIGHT study. So the LIGHT study is called the selective laser trabeculoplasty versus eye drops for first-line treatment of ocular hypertension and glaucoma. It is a multi-center randomized clinical trial that was published on The Lancet. And it found that a selective laser trabeculoplasty should be offered as a first-line treatment for even open-angle glaucoma and ocular hypertension. So this is like a paradigm shift in management of glaucoma. For decades, we were considering giving the patient the bottle therapy and 1 or 2 or 3, increasing to the maximum tolerated medical treatment. But this study showed that you can even start by laser as a primary treatment and it will give the same effect. The contraindication to the laser trabeculoplasty, any case of inflammation or neovascularization, you shouldn't do laser. It will aggravate the inflammation, and this inflammation will result in fibrovascular membranes formation and contraction, causing aggravation of the neovascular glaucoma. So you shouldn't do that. In eye syndrome, also, it will not be effective. There will be already a sheet of endothelium covering the trabecular meshwork. Synechial angle closure, we just mentioned that the angle here is covered by synechia. So how can you point the laser to the trabecular meshwork? Developmental glaucoma will have abnormal angle. So you will not find the normal anatomical structures of the angle, and also there will be angle dysgenesis. Can try in angle recession, but usually it doesn't work. And if also there is lack of effect in the fellow eye, so you shouldn't do it. So mostly you are doing it for non-complicated cases or virgin eyes with primary glaucomas, as they will show more incidence of success. Complications that 20% of patients will get high intraocular pressure after laser, low-grade iritis, as I told you, it will cause inflammation. Also, it causes hyphema and peripheral anterior synechia. It can cause peripheral anterior synechia itself and causing corneal edema and hyperopic shift. Another form of laser, which is the laser peripheral iridotomy. The indication for that it will cause mechanical pupillary block, or the solid indication for the laser peripheral iridotomy is the pupillary block. So doing a PI, it will break the vicious circle and allowing another alternative passage to the aqueous. Contraindication is a flat anterior chamber, as you are risking the corneal burn, as there is iridocorneal touch. A corneal edema, you will not be able to visualize and focus your laser beam onto the iris. 360 degrees peripheral anterior synechium, the laser will not be effective, and the new vascularization, it will cause hyphema. So complications, intraocular pressure, a spike, understandable. This will result in release of pigments. These pigments can cause iritis, and the iritis will cause hyphema. The iritis will cause inflammation and high intraocular pressure spike. It could also present with hyphema as you are maybe hit the laser into a blood vessel, and diplopia if the PI is within the visual axis or within the visible area of the palpebral fissure. Another form of laser called the iridoplasty, laser iridoplasty. So when there is a opposition between the iris, peripheral iris to the angle, we do laser iridoplasty. So if there is persistent oppositional closure after peripheral iridotomy, so this means that there is another mechanism rather than pupillary block. So we do it mainly for plateau iris, as I told you, and nanophthalmos. In plateau iris, there is a hump which is closing the angle. So why not doing these peripheral burns that will pull the iris away from the angle? Also in patients with nanophthalmos. In the patients with nanophthalmos, the lens large, bulky, pushing the peripheral iris toward the angle. Why not giving peripheral laser burners that will pull the iris away from the angle? Contraindication will be the same as laser iridotomy, like flat anterior chamber, corneal edema, 360 peripheral anterior synechium and neovascularizations, and it will be also the same complications, intraocular pressure spike, anisocoria, because you are doing burns in the iris, so affecting the iris muscles, leading to affection of the spice of the pupil compared to the other eye, pigment dispersion because of the iris burns, and endothelial damage. Okay. Okay, so let's now move to the next topic. Okay, Dr. Islam, mechanism of the selective laser trabeculoplasty. Well, selective laser trabeculoplasty will shoot like short pulses of low energy light to target only the melanin. That's why it's called selective. Target only the melanin-rich cells in the trabecular meshwork. So it's called selective because it will target only the melanin-rich cells. So this will result in clearing these cells, resulting in opening of the trabecular meshwork. Maybe that's why will be very beneficial for patients with pigment dispersion, because their trabecular meshwork is full of pigments. That's why it will clear these pigments. Okay, let's now talk about another procedure, which is the cyclodestruction. Cyclodestruction is a procedure to destroy the ciliary body, which is the aqueous source. So it can be done by several ways. The cyclocryotherapy, this is by freezing the ciliary body, causing damage to the ciliary body by freezing. So by application of the cryoprobe over the ciliary body, and this was like, I think that it is not done anymore. I think that I done it in my early residency couple of times, and then it was switched by the cyclophotocoagulation, but I don't know if other places in the world may be still using it, but it is still a way for the cyclodestruction. Another way is called the cyclodiode photocoagulation, which can be done transscleral from outside. So by application of the diode laser over the ciliary body, this is an infrared longer wavelength laser that will cause damage to the ciliary body, or we can do it by endoscopic cyclophotocoagulation. So doing laser burners over the ciliary body from inside. Indications, it is mainly for patients with poor visual potential, like in patients with neovascular glaucoma, or poor candidate for surgery, like a patient who is refusing surgery or where the surgery will not be very successful, and the blind, painful eye, except the endoscopic. So endoscopic can be done still for visual for good visual prognosis, and also it is by many glaucoma specialists right now use even the external or transscleral cyclodissection for cases with good visual potential. So maybe in the past they didn't have the experience enough that they will titrate their dose or their treatment, as they were afraid of hypotony, the persistent hypotony post-operative. But nowadays it is becoming more widely acceptable to give or to do cyclophotocoagulation as a primary treatment for seeing eye for management of case of glaucoma. The technique is, here is also another very important thing that is asked in the exams, which is you are increasing the power of, like, you can find the power and duration and number of pulses. So you are increasing the power. How would you do the cyclodiode or cyclophotocoagulation? By increasing the power until you hear a pop sound. So is it this is the optimum power when you hear the pop sound? No. After you hear the pop sound, you should decrease the power. You just decrease the power just below when you hear the pop sound. The pop sound here means that there is a cellular water. The cellular water is boiling. Like when you do the application, you are boiling the water of the cells. Like when you are boiling water when you are making a cup of tea. So it is the same thing. We don't want to completely damage the cell by boiling its water. We just decrease the power a little bit just below the pop sound. So this is specifically was asked before. Complications, it could result in loss of vision, hypotony, pain, inflammation, endophthalmitis if you are doing the endoscopic, cystoid macular edema, hemorrhage, retinal detachment, phthisis bulbi if you are doing excessive application with damage to the whole ciliary body, sympathetic ophthalmia. Finally, let's now talk about the surgical procedures or the surgery for the trabecular meshwork. First of all, the subscleral trabeculectomy. Subscleral trabeculectomy is a surgery in order to create a window between the anterior chamber and the subscleral space. So by doing excision of the trabeculum or trabecular meshwork or trabeculectomy, we are creating a shortcut between the anterior chamber and the subscleral space so that we are bypassing the damaged trabecular meshwork. So when we should do the subscleral trabeculectomy, we should, the clear indication is when there is progressive optic neuropathy or visual field defect, and the intraocular pressure is too high for the disease, and the maximum tolerated medical treatment was reached. So this means that for primary open angle glaucomas, or for primary glaucomas usually, is you are giving the, or let's say the primary open angle glaucoma, you are giving the full tolerated maximum medical treatment. The patient cannot, and you are ensuring the patient is compliant, and you don't have any more drug to offer the patient, and still he is deteriorating, and still he is losing his visual field and losing his optic nerve. That's when the subscleral trabeculectomy is indicated. Or it can be used as a primary surgery for other resistant glaucomas. So not all glaucomas like the same, but it depends on the condition. Contraindications for subscleral trabeculectomy is the same like risk factors for failed BREP or failed TRAP or failed BLIP. It is the same thing. So when should you consider that this patient will not benefit from subscleral trabeculectomy? First of all, if it's a blind eye. If it's a blind eye, why to bother? Why should you go do a subscleral trabeculectomy? And the risk of endophthalmitis at those patients, you are opening the eye, and there is long list of complications. Why to bother in a blind eye where you can just do like a cyclophotocoagulation? Some relative contraindications, such as active anterior neovascularization. As I told you, if there is active inflammation or active neovascularization, this is a risk factor for failure of trabeculectomy. You should consider either control of inflammation and regression of the new vessels in order to consider trabeculectomy. Otherwise, think of another alternative, like glaucoma drainage device. Active iritis, as I told you. So you see, inflammation and the new vascularization are always in this lecture, always go hand by hand in the drugs and in the surgery. Extensive conjunctival injury, because conjunctiva here is very precious. You don't want to open and you find that you are short of conjunctiva. Conjunctiva for glaucoma is like the capsule for cataract. You need to have enough conjunctiva in order to be able to make the blip or to make the trabeculectomy. Okay, that's why when you are doing any conjunctival surgery, like doing like pterygium with conjunctival autograft, you have always to consider if this patient is glaucomatous or not. Because if you are taking an autograft, like you are taking conjunctival graft from his own eye, and this patient has glaucoma, you will make the mission for the glaucoma surgeon very difficult, because he has shortening of the conjunctiva. Patients with thin sclera, making the surgery very, very difficult. Thin sclera more liable to perforate with uveal prolapse, and so you are making a partial thickness scleral incision, and for those patients with a thin sclera, it will be very, very difficult. Necrotizing scleritis, also it's understandable. So it will be also having very, very thin sclera. Less successful in young and black. And this doesn't have any explanation, but it was asked before in the MCQs. The risk factors or the failed trab is more to be failing in the younger age group and in the black individuals. So how can we increase the success? We said that why does it fail? So how can we increase the success? It will be by using the antifibrotic agents. Antifibrotic agents are agents that will prevent the healing. So actually, when there is any wound, we are creating a wound. In this case, we are creating a wound by making this subscleral flap and then opening the trabecular meshwork. We are creating an artificial wound. So the fate of any wound that it will heal, but if it heals, it will result in closure of the flap and will prevent the drainage of aqueous. So we want something that will prevent this that trap door from healing, and this is the rule of antifibrotic agents. So since the use of them, they showed great success or show improvement of the success of the trabeculectomy, but unfortunately, they will also show increased complications. So they have been linked more with a scleral melting, corneal infection, corneal thinning, and others. Persistent epithelial defects as well. So for those patients, or we have two main drugs. The mechanism of both were asked before in the MCQs. The 5-fluorouracil and the mitomycin C. 5-fluorouracil, it will inhibit the fibroblast proliferation by interfering with the DNA synthesis through the inhibition of thymidylate synthetase or thymidylate synthase. This is the name of the enzyme that was asked before. This is the enzyme which is inhibited by the 5-fluorouracil, leading to inhibition of DNA synthesis. This is highly alkaline and will cause epithelial, or what the side effects, it will cause epithelial defect and blood leakage. And in this case, we should inject 5 to 10 microgram. Mitomycin C is another agent. It's called alkylating agent. The mechanism of action that it will cause cross-linking to the DNA. It is applied in the form of pledget, or that is soaked with 0.1 to 0.5 milligram per milli, or injection of 5 to 30 microgram of mitomycin C. So let's see how is the subscleral trabeculectomy is formed. We are starting first by making a conjunctival flap. So doing periotomy, limited periotomy in the superior limbus. and doing the removing the tenon. Let me just try to explain. So doing the limited periotomy and then elevating the conjunctiva flap. This is a fornix-based flap, and doing dissection. So we do proper dissection, trying not to make any opening or any holes in the conjunctiva, trying to avoid any buttonholes. Then also dissect and remove the tenon, trying to remove as much tenon as possible to prevent the possibility of tenon cyst formation. Doing cauterization, then we do the subscleral flap. So we are creating a partial thickness scleral flap door, and then dissect this flap. It will be around half depth of thickness of the sclera until we reach the limbus. Then apply the pledget with mitomycin under the conjunctiva and under the flap. And then after 2 minutes, we are removing these mitomycin pledgets, and we are making sure that we removed the we removed the correct number, so we don't leave anything behind. We pre-place the sutures, then opening or doing the paracentesis. Then we are now cutting the trabecular meshwork. So we are doing the trabeculectomy, like by 1 millimeter block of the trabecular meshwork is excised. Then we pull the iris and make a peripheral iridectomy. Then closing the scleral flap. So here we are making the paracentesis to check the patency of the flap, and it was patent. There is drainage of the aqueous. So closing the scleral flap, then closing of the conjunctiva. We know the mitomycin is washed by the just doing excessive, like doing 2 or 3 minutes wash. That's how you make sure that you wash the conjunctiva. There is no parameter. It is just by duration or by excessive washing. So what are the complications, the early post-operative complications that you might find after the trabeculectomy? That you might find low intraocular pressure or high intraocular pressure. The low intraocular pressure could be due to flat EC or associated with flat anterior chamber. And in this case, it could be due to overfiltration. There could be that your scleral flap is leaking, or your bleb, the conjunctiva itself, is leaking. So how can you differentiate? You will differentiate by the CDL test. So if there is scleral flap leak, it will be negative CDL test, while if there is a positive CDL test, then this means that there is a bleb leak. If there is no overfiltration, so then the other options will be, it could be a choroidal effusion, and this can be diagnosed by presence of a grayish red reflex and by doing ultrasound, and this should be treated by systemic steroids. And or if there is no overfiltration or no choroidal effusion, so by exclusion, it could be a ciliary body shutdown. If there is high intraocular pressure, it could be either associated with flat anterior chamber or deep anterior chamber. For the flat anterior chamber, it could be due to high intraocular pressure due to pupillary block. It can be blocked by blood, can be blocked by pigment or by viscoelastics or whatever. So this will be one possibility, but after testing the PI, if it was patent, then it could be a suprachoroidal hemorrhage, and in those patients, they will have reddish red reflex, and it can be diagnosed by ultrasound. If the PI is patent and if the suprachoroidal hemorrhage is not present, so by exclusion, the cause of high intraocular pressure and the flat anterior chamber is malignant glaucoma. So there is rotation of the ciliary body and resulting in aqueous misdirection causing malignant glaucoma. If there is high intraocular pressure with deep anterior chamber, so this means that the ostium, the side, is blocked. It could be an internal block, that like the ostium inside the that you made is blocked. It could also be blocked by fibrin, by blood, by pigment, by viscoelastics, or if the bleb is high, then it is called encapsulated bleb or tenon cyst. So deep anterior chamber with high intraocular pressure with high bleb is called encapsulated or tenon cyst. Other late complications, it could be blebitis and endophthalmitis. So this is a blebitis, the commonest organism asked before in the exams, Staphylococci, Streptococci, and Haemophilus influenza. Again, the commonest organism for blebitis or inflammation of the bleb is Staphylococci, Streptococci, and Haemophilus influenza. And this is has a very characteristic feature. It's called milky white bleb. Milky white bleb, as if the bleb is milky white and surrounded by intense hyperemia. So in this case, you are diagnosing blebitis after exclusion of endophthalmitis. So this patient should be doing ultrasound to prevent or to guard against endophthalmitis. What will be the risk factors? What will be the risk factors to develop blebitis and endophthalmitis? It will be if the patient has pre-existing ocular infection, like blepharitis, conjunctivitis, ocular trauma, nasolacrimal duct obstruction, or he is contact lens user. So we should, those patients who have done TRAB, they shouldn't be wearing contact lens. Or if there is chronic bleb leakage, like any leakage, it will can result in entry of organism resulting in infection. Male, he may be more liable to trauma. Young age as well, liable to trauma, and inferior position. So if you find that like trauma, like the conjunctiva is scarred superiorly and you do the bleb inferiorly, you are risking for endophthalmitis. There is also another mode of treatment for patients with glaucoma. It is just simply by doing clear lens extraction. And this is reserved for patients with primary angle closure glaucoma. There is another important study called EAGLE study, effectiveness of early lens extraction for the treatment of primary angle closure, EAGLE. And this was done to check for the effectiveness and efficacy of why shouldn't we do clear lens extraction instead of doing PI in patients with primary angle closure glaucoma? So those patients, they have crowded angle, they have crowded eye, their eyes are small for the size of the lens. So why shouldn't we remove the lens instead of doing PI? And this study showed that the clear lens extraction showed greater efficacy and was more cost effective than doing laser PI, and should be considered as an option for the first line treatment. So this is another mode for surgical management of glaucoma, is to do clear lens extraction. Another way is to do combined, like to do both cataract or lens extraction and trabeculectomy. So what will be the problem? The problem is that the success rate of trabeculectomy will be lower when combined. Like, for example, like assume that the cataract surgery was complicated by vitreous loss. So this vitreous loss will be causing more risk of glaucoma and so on. So you are increasing the risk of failure of trabeculectomy by the cataract surgery. So when we consider it like if patient has primary angle closure glaucoma, as I told you, so the cataract extraction alone unlikely to lower the pressure to target, like the pressure will be like, we need to decrease the pressure by 20 millimeter mercury, and the lens extraction will only decrease the intraocular pressure by like 4 or 5 millimeter mercury. So this is not enough. We need to combine it with the trabeculectomy. And according to the ocular hypertension treatment study, the lower intraocular pressure after cataract extraction effect decrease with time. So this study showed that you doing cataract extraction alone is not enough to control the intraocular pressure over long term. Intraocular pressure lowering equal one hypotensive drop and the greater reduction with the highest IOP. So the more the highest the IOP, the more reduction with the combined cataract and trabeculectomy surgery. Finally, the last resort for the glaucoma drainage devices, for the glaucoma management will be the glaucoma drainage devices. Glaucoma drainage devices, they have certain indications. It could be after trap failure. You did trabeculectomy for a patient and then this surgery failed. Or if there is active uveitis. So we mentioned that active inflammation or active neovascularization shouldn't, the trabeculectomy almost always fail. So active uveitis, neovascular glaucoma, we should do glaucoma drainage devices. Inadequate conjunctiva, so the conjunctiva is scarred or lost or short, so we do glaucoma drainage device. Aphakia show more success rate with the glaucoma, with the drainage devices. And if the patient is dependent on contact lens, so we said that the contact lens will increase the risk of endophthalmitis, but the patient is dependent on it, so we revert it for glaucoma drainage device. So what are these glaucoma drainage device? First of all, there is one called Ahmed valve, Ahmed drainage valve. And the advantage of Ahmed valve is that it is more safe. It has less incidence of complications. What are the complications? Like diplopia, as it will cause compression of the extraocular muscles. This tube will may cause corneal decompensation, or this tube over the sclera may cause erosion. So there are less complications with Ahmed valve. However, there is another kind of valves called the Burvelt valve, and this valve is more successful. It will show less IOP or more IOP reduction. And this is the result of what's called the tube versus trabeculectomy or TVT study. So that the Burvelt has higher success while Ahmed has higher safety. Or Ahmed has less complications, but Burvelt has less IOP. Okay, so again, I encourage you, if you haven't seen my lecture, the glaucoma trials, you will find it in the clinical trials and the studies in ophthalmology. It will be, this lecture is already open for free. So it will be present at your application. Please watch it. It will be 1 hour of summarizing the landmark studies in glaucoma. Will mention all details about ocular hypertension treatment trial or ocular hypertension treatment study, normal tension glaucoma study, the tube versus trabeculectomy study, and the others. So please check it. Let's see this video showing the steps of the glaucoma drainage. So first of all, we do fixation suture or traction suture in order to help fixation of the globe. So doing the periotomy and conjunctival dissection, trying to dissect posteriorly, because we wanted to place our valve 8 millimeter from the limbus. So this is, what we are doing here, what's called priming, like injecting of fluid inside the tube. So we want that this tube to be air-free. We don't want any air inside it. So this priming is the first step to do with this valve. Then we are placing the valve in the superior temporal quadrant. This is the typical, and fixating it with a suture. So the distance between the valve and the limbus should be 8 millimeter. By the way, this is the Ahmed valve. So the tube here, we are placing it, we are cutting the excess tube, and we are doing a paracentesis and injection of viscoelastic. Now placing 23 gauge to making opening into the anterior chamber to place the tube inside it. And actually this will be the hardest step in the procedure, which will be embedding the tube inside this this tunnel. This tunnel is around 4 millimeter, and then fixing the tunnel and putting a scleral patch graft. This is very important to put a scleral patch graft, as one of the side effects of this or complications of this surgery is erosion. So this tube, the tube will erode. The tube could erode the conjunctiva and this will need to readmit the patient to the surgery and putting a patch scleral graft or corneal graft or corneoscleral graft, whatever available. So here we put a corneal graft, maybe to become I just make this will make it more cosmetically not appealing, but it will be just what is available. Then closing the conjunctiva. So here we have three important measurements. First of all, the distance of the valve from the limbus, it is 8 millimeter, and the tunnel length, it is 4 millimeter. And when you combine both 8 and 4, it will be 12 millimeter is the length of the tube. So that if you want to know what is the length of the tube, it is 12 millimeter. So by combination of interrupted and running sutures, we closed the conjunctiva, and the traction suture is also removed. Easy. And that's it. And this is the end of the glaucoma. And how do you think the glaucoma? Is it easy? I think it is easy. It is based mainly on understanding. That's what makes it easy. At least for me.